Hey, this is Ali Sue. Welcome to Pharmacy Entrepreneur TV. If you are a past, present, and future pharmacist, and you want to create a business and life you love, this is the show for you. Today, we're very excited to have Professor Bruce Berger on our show. Bruce is president of Berger Consulting and Emeritus Professor at Auburn University. He has developed comprehensive motivational interviewing training for healthcare providers and Auburn University Motivational Interviewing Training Institute. He has taught motivational interviewing in healthcare and methods for providing treatment adherence for over 30 years. Bruce's research interests include health behavior change and improving treatment adherence. He has written 3 books, written or presented over 900 papers or seminars on these topics. He has attracted over $3.5 million in funding to support his research. Bruce has been a consultant and trainer for the U.S. Air Force, U.S. Army, Pfizer, Procter & Gamble, AbbVie, Novartis, AstraZeneca, Sanofi Aventis, GSK, and over 50 health plans. Bruce is the recipient of numerous awards, author of the book Motivational Interviewing for Healthcare Professionals, A Sensible Approach, and the 8 hours accredited Motivational Interviewing e-learning program for healthcare professionals. Let's welcome Professor Bruce Berger. Hi, Dr. Bruce Berger. How are you today?
I'm great. How are you, Ali?
Good, thank you. We're so excited to have you on the show. You have over 30 years of experience on medication treatment adherence. We can't wait to hear and learn more about that.
It's an important topic. In the U.S. alone, non-adherence costs over $500 billion a year in healthcare costs. So it's really important.
Yeah, great. And then same as anywhere else in the world, we're in Australia here, and pharmacists feel stuck a lot of times when we want to help the general public and we want to give a lot of information, but we feel rejected and patients don't want to hear about it, or they're not making any behavior changes. So yeah, we can't wait to hear about that. So before we get into the details of motivational interviewing, tell us a bit about your pharmacy journey.
Well, I actually started off working in a pharmacy as a delivery boy and short order cook. They had the pharmacy I worked in had a little diner area. And so I actually worked cooking there, and I also delivered medications to people. And it was really my first exposure to behind the scenes pharmacy. And I really liked it, and the independent pharmacist that I worked for said that if I went to pharmacy school, he would help me out. And so I went to pharmacy school, graduated from the Ohio State University many, many years ago, and practiced pharmacy for about 2 years and decided to go back to school. I was intrigued by the relationship. I worked with another pharmacist in a chain drugstore, and the patients all wanted to come and talk to me. And I think part of it was I knew their names, I knew something about their families, and I made an effort to do so. And so I started learning very quickly that the relationship is everything. And I went back to school then, into graduate school, to study health psychology and health communication, to learn more about how the relationship impacts treatment adherence and treatment outcomes. And so then I went back to Ohio State and got a master's and PhD, and then started teaching in schools of pharmacy. Taught at Auburn University for 28 years before I retired to do full-time consulting and training in motivational interviewing.
Wow. We're dying to know that what makes you that so special and that all patients wants to talk to you.
Well, I think motivational interviewing it's a patient-centered form of counseling, truly a patient-centered form. And we talk a lot about patient-centered in healthcare, and half the time we don't know what we're talking about. Because the whole idea of patient-centeredness is I'm there for them. They're not there for me. I owe them caring and concern. They don't owe me any of that, and that's part of what it means to be patient-centered. And so I got interested in motivational interviewing because it was such a caring approach to talking with and listening to patients. And it actually started in substance abuse. And William Miller, who created motivational interviewing, was a clinical psychologist. To this day, motivational interviewing is still the most effective intervention in substance abuse, has the lowest rate of relapse. And I started thinking, my goodness, if he could do this with people who are addicted to substances, how hard is high blood pressure? And he really changed how counseling took place and created the words motivational interviewing. I think the words are a little bit of a misnomer because we're really not trying to motivate patients. We're trying to assess their motivation. That's very different. If you think your job is to motivate your patients, you have an impossible job. If you think your job is to begin to understand their motivation, in other words, what's causing them to do this behavior but not do this behavior? Why will they take their medicine but not change their eating habits? Or why will they change their eating habits but not take their medicine, for example? And so motivational interviewing is about exploring that and not judging the patient. I call it a meeting of experts. As a pharmacist, I might be an expert on drugs, but the patient's an expert on what they understand about their illness and its treatment. My job is to explore their understanding, because without knowing that, I don't know what to tell them. And the reason that this idea of a meeting of experts or an information exchange is so critical is because if we think information is enough, if we think just educating our patients is enough, then how do you explain how some healthcare professionals are overweight or smoke? If just knowing's enough, no healthcare professional should be overweight or smoke, right?
Yeah.
Yep. So there's got to be something else going on. So my job is to really lovingly explore with the patient, how are they thinking about their illness? How are they thinking about their treatment? What's keeping them from doing these things? What would make them want to do these things? With the understanding is it's their illness, it's their decisions. I'm there to help if they want it, but they have to decide.
Wow. It's really reversed that. It's a different way of thinking.
Well, it is. And the problem is the other way of thinking where we tell people what to do, right? It doesn't work. The only time telling people what to do works is when they're ready to do it. And motivational interviewing was developed for patients who are either ambivalent or resistant to change. I'm not sure I want to take this medicine. I don't want to quit smoking. I don't want to lose weight. That's who am I, and I'm going to call it MI so we don't have to keep saying motivational interviewing. That's who it was developed for. Patients who are not ready to engage. So if you tell people who are not ready to do something to do it, they defend why they won't do it.
Yeah.
If you tell a smoker, you need to quit, and they're not ready, they're going to give you all the reasons in the world they can't.
Yeah.
So it doesn't work. Persuasion does not work with people who are not ready. And yet that's our primary way of communicating in healthcare. We try to convince somebody to do something. And when they push back, we say they're stubborn, when the real problem is we don't know how to talk to them.
I see. Wow. That's great. We're so excited. So now next question is, how do we start? How do we talk to them And in a busy pharmacy setting, we don't have time to understand more about patient, to ask more questions. What do we do then?
Well, let me say this first. If we think our job is to dispense drugs and to dispense information, we won't have a job in the near future. Amazon has already paired up with Apple, and Siri is giving drug information to patients.
Wow.
You know, and Amazon has a huge distribution network for drugs now, right? So if we think that our job is going to be the dispensing of drugs and drug information, we won't have a job. We won't. And yes, we have a short amount of time oftentimes in practice, but the way we've developed motivational interviewing is called brief motivational interviewing. And so we can have an impact in 3 to 5 minutes, all right? Now, I'm going to be honest with you. If somebody has a new patient with diabetes who has new medication, and we think in 30 seconds we're going to do motivational interviewing and have them taking their medicine, it's not going to happen. I mean, realistically, what we've got to start thinking about is, how do I up front have this conversation with the patient so I'm not having 10 conversations downstream about non-adherence? So I'm gonna when I have a new patient with diabetes, very first thing I'm gonna say to them is, tell me a little bit about, in your own words, what does diabetes mean to you? Because what I want to find out is, do they think it's important to do anything about it? You know, how important is it for you to get your diabetes under control? What's your understanding of what can happen if you don't control it? Those are the kinds of key questions I want to ask patients up front. And then I'm going to listen very carefully to how they're making sense of things, because that's going to tell me what I need to do. If we do that well up front, and by the way, you can do that really well up front in 5 to 10 minutes at most with new patient, new illness, new prescription. You won't have to be doing that all the time with refills, because you'll have established with this patient what they know and how to begin to address the issues they have.
Can you walk us through the steps or journey at the counter, pharmacist? How should we approach when the patient presents the new scripts to us?
I do a lot of work with, are you familiar with MTM?
Oh yeah, MTM, therapy? Yeah, in Australia.
I do a lot of work with medication therapy management companies.
Yeah.
And we actually do a lot of training and motivational interviewing on how to even start the call, and the call basically is one in which we say to the patient, we're really here to be a source of information, a resource for you, and to help you get the most benefit from your medication. I see that you have diabetes. Tell me a little bit about how important it is to you to treat your diabetes. And so we use an open-ended question to kind of get an entree into the discussion. Now, if the patient even says, why are you talking about this? Isn't that my doctor's job? We usually say, I see myself as somebody who supports your doctor. A lot of times your doctor doesn't have time to talk to you about the medication and how it works and any problems that you might have with it. And I see myself as somebody supporting the efforts of your doctor focused on medication.
Well, yeah, that's a great way to start. We get asked all the time. I've already spoken to my doctor, and I'm just here to collect my medication off.
Okay. And then in which case I'll say, I'm really glad that you've got a relationship with your doctor, that you feel comfortable speaking with them. Do you mind if I ask you a question or two? And then certainly I'd like, I want you to be able to get on your way. But I hope you'll be able to see me as a resource to be able to answer questions about your diabetes and your medication. And usually after I say, would you mind if I ask you a few questions? They'll say, okay. And I'll say, so, tell me in your own words, what does having diabetes mean to you? And how important is the medication to you in controlling your diabetes?
Yeah.
And then I just listen to what they tell me, on a lot of the MTM calls that we get, a lot of patients will say, in this day and age, why are you calling me? How do I know you're really a pharmacist? And again, from a motivational interviewing perspective, what the patient is saying to us is, I'm concerned about talking to somebody who's not a pharmacist. I don't want to get scammed, right? And so in motivational interviewing, we teach people to listen for the emotions and how the patient's making sense. So if I have a patient who says to me, how do I know you're really a pharmacist? Because we're on the phone now, right? The very first thing I'll say is, so, the information about your condition and the medications you take is very personal. And you want to make sure that whoever you're talking to is legitimate. If you were that patient, what would you say? So what am I telling you when I say that to you?
Like, you know what you're talking about?
And then I get what your concern is.
Yeah.
And so being able to say to a patient, this is personal information, and you want to make sure that you're talking to somebody who's legitimate.
Yeah.
And the patient usually would say, yes, right.
Yeah.
And I say, you have every reason in the world to question that. I'd say that too. I don't get defensive because I'm just following the patient. And then I would say, and if the patient, for purposes of patient confidentiality and privacy, the patient has got to be able to tell me some things about their name, their address, etc. If they won't give that to me, usually because they're not sure yet, I'll usually say something to the effect, would you like to ask me some questions about some of the medications you're taking so that I can show you that I really am a pharmacist?
Yeah.
So again, it's non-threatening, it's non-defensive, and it says to the patient, I'm here to help.
Wow, that's great. So what are some of the examples of non-MI approach and MI approach so we can tell the difference?
Well, let me give you an example of a patient we called. And I'm going to tell you what people typically do. I've had the opportunity over the years to listen to thousands of hours of phone calls between healthcare professionals and patients. It's pretty bad, I'll tell you. And again, all the calls, the patients are de-identified for, HIPAA, which is our, are you familiar with HIPAA? That's the Patient Confidentiality Act here in the United States, Privacy Act. So anyway, there was a woman that was taking a medication for her high blood pressure. She was 30 days late on a 90-day supply. We called her up and the pharmacist said, hi, I'm Bruce Berger and I work for your health plan. Mrs. Jones, we noticed you're about 30 days late on your 90-day supply of your medication. She was taking lisinopril, all right? Are you having any difficulties? And she said, no, I take it about 4 or 5 days a week. My blood pressure never goes above 150 over 100, and I feel fine. Now, are you noticing any problems there? Well, and what is she telling you? She's telling you she takes the medicine 4 to 5 days a week. She's supposed to take it every day, right? Her blood pressure never goes above 150 over 100. Is 150 over 100 good?
No.
No. And she said, and I feel fine. So what she's saying to me is her sense is everything's okay.
Yeah.
Now, typical healthcare professional would immediately say, well, you really need to take the medicine every day, and 150 over 100 is high. Now, do you hear the word stupid at the end of that sentence, even though it wasn't said? In other words, whenever we say to a patient, listen, you need to take it every day, and 150 over 100 is high. Stupid. We're saying stupid. even if we don't say it out loud. This is a typical way that we respond. We immediately start correcting the patient. And then we wonder why the patient becomes defensive. Okay? Here's what I would say using motivational interviewing. I want you to think about what the woman said to me. Her sense is everything's okay. She feels fine. She's taking it 4 to 5 days a week, and she's operating under the belief that 150 over 100 is okay, right? So here's what I would say using MI. So because you're feeling okay and your blood pressure never goes above 150 over 100, by taking it 4 to 5 days a week, you're kind of thinking, if it's not broke, why fix it? Everything's okay. And she said, exactly. Now, what did she learn from me?
That you understand her.
Did I pass any judgment?
No.
Did I correct her?
No.
Not at all. So now, after I say that to her, because I'm doing two things. I want her to know I get it, but I also want to give her an opportunity to say, yeah, that's exactly right. Or to correct me if I didn't get it, okay? Now, after she said exactly, I said, great. I said, would you mind if I shared a few thoughts with you, and I'd like to hear what you think? You hear how conversational this is. So she said, sure. Now, if I had looked at her or said to her, your blood pressure, if your blood pressure is 150 over 100, it's too high, and you need to take your medicine every day, I'd like to talk to you some more about your medicine, she would not be saying okay. And we would blame her for being difficult.
Wow, yes.
When I'm the one who's difficult. You follow what I'm saying?
Yes.
So I said, would you mind if I share a few thoughts with you and you tell me what you think? Notice I don't say, would you mind if I shared some clinical information with you and you tell me what you think? I said very conversationally, would you mind if I share a few thoughts with you and you tell me what you think? She said, sure. Why would she not say sure? I've not said or done anything other than understood her, right? So here's what I said then. I then said, we know that when blood pressure goes above 130 over 80, your risks of stroke or heart attack go way up. With your blood pressure being 150 over 100, your risk of stroke or heart attack is elevated. Now, I suspect that if you were willing to take the medicine every day, your blood pressure and your risk would come down. What are your thoughts about taking the medicine every day? How long did that take?
10 seconds. Wow. Very effective.
Very short, right? Yeah. Now, notice what I did. Her sense was, I'm fine. What I'm listening for is, how is she making sense of things? She was making sense by thinking, I feel okay, so I must be okay. What she doesn't understand, or what's missing from her logic, is that you can feel okay with high blood pressure and be at risk. That's what I filled in. But I only knew to fill that in by listening to her expertise. This is the exchange. Follow? And so, notice I also didn't say to her, therefore, you need to take your blood pressure medicine every day. What did I say? I suspect that if you took your medicine every day, your blood pressure and your risk will come down. What are your thoughts about taking it every day? And the reason I do that is I don't dictate, because it's not my decision, it's hers. And I want to know, what has she thought about this new information I've given her? I don't find that out if I tell her, therefore you need to take it every day. I do find out what she thinks about it if I say, what are your thoughts about taking it every day? And you know what she said? I had no idea that 150 over 100 was high. I felt okay. She's taking it every day now.
Wow.
So that's an example of motivational interviewing. Would you like to hear another one?
Yes, please.
Okay. I'm doing a lot of work with a pharmacy, a national pharmacy chain here in the United States. And they were going through my e-learning program, and we would have webinars where they could ask me questions. My e-learning program group rates people get webinars with me also as part of the deal. So they said, okay, we got this patient. This happens all the time. He's taking blood pressure medicine, never takes it more than 4 days a week. We call him up. Hey, Mr. Smith, we notice you're taking your medicine about 4 days a week, and you really need to take it every day. And he says, yeah, I know. I'll take it every day next time. Guess what happens a month later?
Didn't take it.
He's still not taking it more than 4 days a week. And they said, what are you supposed to do? And I said, let me ask you something. When you tell that patient you need to take it every day, what do you learn? And they said, what do you mean? I said, what do you learn? I said, other than he tells you, okay, I'll take it next time, right? I said, what do you learn? They said, nothing. I said, that's correct. I said, that's the problem. I said, here's what's interesting to me. What is he doing? They said, he's taking it 4 days a week. I said, why? They said, we don't know. I said, that's the problem. I said, here's what I would do using motivational interviewing and something called, and motivational interviewing is built on positive psychology. Here's how this would work. I would say, hey, Mr. Jones, I notice that you're taking your medicine about 4 days a week. That's a good start in getting your blood pressure down. What's made it important for you to take it on those 4 days? Do you hear how different that conversation is? What's made it something has made it important for him to take it 4 days a week. What is it? That's his motivation. And so once I learn about that and find out about that, now I have something to base a conversation on. And I can also explore what's made it difficult to take it the other 3 days. We hear patients say things like, who have diabetes, I'll take the medicine, don't expect me to do anything else. Guess what healthcare professionals say right away? You're not going to get your diabetes under control if you don't do more than take the medicine. Scold, scold, scold.
Yeah.
And the patient gets turned off and we think they're stubborn. Here's what I would say. I'm really glad to hear that you're committed to taking the medication. That's a really important step in getting your diabetes under control. What's your understanding about what is the impact of changing eating habits or increased physical activity on helping your medication work more? And the patient might say something like, well, I know it's supposed to be better for me, but I don't know that I'm going to be able to change my eating habits or get more exercise. And I'll say, and you know, it really is up to you. What seems to be the biggest barriers for you to wanting to change your eating habits or maybe get some more physical activity? And the patient says, I hate to sweat. And so I said, okay. I said, so a big barrier for you is you think of exercise in terms of sweating. And she said, yes. And I said, if you could get some physical activity and not have to sweat at all, and it didn't have to be more than 15 minutes at a time, would that interest you? Do you hear how different this conversation is?
Yeah, you're asking for permission, providing information, asking their thoughts.
That's right. It's their illness.
Yeah.
It's their life. It's not my job to control their life. It's their job to control their life. It's my job to care about them. And it's my job to not cause them. Do you know about a concept called face loss? Face loss. Yes. You know, face loss is actually an Asian culture concept. It started losing face.
Losing face, yeah.
Yes. And when people lose face, when we look at a patient and say, well, 150 over 100 is high, and we correct them, or you need to take it every day, not 4 days a week, we cause them to lose face. Our research shows when you cause somebody to lose face, they do one of two things. They either discount everything you're saying, or they don't listen at all. Because not only do they not like the information, they don't like you. And the relationship is everything. Motivational interviewing causes no face loss. I'll give you one more example. And again, positive psychology is so important because even when a patient's not adherent, they're doing something. I want to find out what's motivated them to do the something. If they're only taking the medicine 60% of the time, we always say, well, they're only taking it 60% of the time. They're taking it 60% of the time. What's made it important for them to take it on that 60%? What's keeping them from taking the other 40%? And sometimes we find out they can't afford more than 60%, or they get side effects. They say they get side effects if they take it more than that. Well, whatever the reason is, I begin to now understand from the patient's perspective what the motivation is, what's going on. Let me give you one more. This is a really good one because this is from the same company called a woman up, and she was late on her refill, and they said, Mrs. Brown, we noticed that you're late on your whatever it is. You having any difficulties? And they knew she was not taking all her medicine, right? And she got very defensive, and she says the following: I take my medicine every day. How dare you? What are you implying? Now, we will call her a difficult patient, right? I don't think she's difficult at all. I think her doctor has probably scolded her about not taking her medicine, and she's not wanting to get scolded again by us, so she lies about it. Because it's not safe for her to tell the truth. You follow what I'm saying?
Yeah.
So, if you don't know motivational interviewing, you probably say to her, Mrs. Jones, according to our record, you're not taking it every day. Do we cause face loss?
Yeah.
Defensiveness?
Yes.
And then we blame her. Now, you're probably sitting there thinking, so what do you do?
Yeah.
Right? You know she's not taking it, and she says, I take my medicine every day. How dare you? Here's what I would say. Mrs. Brown, I am so relieved to hear that you're taking your medicine every day. That's the most important thing to me. Believe it or not, I have other patients that take the same medicine that you do, and they skip doses. And their blood pressure's elevated, and they don't even realize it, and they're at risk of stroke or heart attack. And wouldn't that be tragic if they had a stroke or a heart attack when all they needed to do was take their medicine to reduce their risk? So when I find out that you're taking it every day, I feel so relieved. I'm really glad to hear that. Now, if you don't mind me asking, could you tell me what do you do to help you remember to take it every day? I'd love to be able to tell those other patients. What have I just done, Allie?
Wow. So you not actually have that confrontational conversation with her, but using someone else's example and telling her the full story, what the consequences of not taking medications.
If my goal is to prove her wrong, then I will play the prosecuting attorney and say, well, according to my records, you're not taking it every day, Mrs. Brown. If my goal is to care about her and educate her, I'll use another patient as the bad example.
Yeah.
So she doesn't have to be defensive. Does she get the information?
Yeah.
Do you know what one of the women that I did that, or patients that I did that with one time, you know what she said to me immediately? Well, how many would I have to miss? So now she felt safe enough to admit it.
Yeah.
Because I didn't accuse her of anything. So this when people really learn how to do this, it's very powerful. And we use analogies with people. We use analogies about, for example, we had a patient with diabetes who said he had a new prescription and said, I'm gonna give this to you. I want you to put it on your file, but I'm not gonna get it filled yet. I'm not gonna start taking it until I feel bad. And can you imagine what most healthcare professionals would say to her? You don't want to wait till you feel bad. If your doctor said you have diabetes, you need to start taking that right away.
Yeah, that's
right.
Yeah.
And what would she do?
Be defensive or?
And what would we say about her if she got defensive? She's the problem, right?
Yeah.
Here's what I said. I said, so right now, you're feeling okay. If you get to the point where you're not feeling so well, then you'll consider taking this medicine from your diabetes. She says, exactly. So again, I've simply reflected back my understanding of what her thoughts are, right? And her sense is that once she feels bad, then she can control her ailments, which of course we know is not true, because you can feel okay and still have damage start being done, right?
Yeah.
Here's what I then said, would you mind if I, share a few thoughts and you tell me what you think? And she said, well, you can share some thoughts, but I doubt that I'm going to do anything differently. And I said, fair enough. It's your illness and you have to decide what you want to do. So here's an analogy. Here's a way of thinking about this. This is what I was saying to her. I said, when we have diabetes, we have too much sugar in our blood. Now, we need a certain amount of sugar to have energy for our organs and to work properly. When we have diabetes, we get too much sugar in the blood. Now, if you think about a stack of pancakes, if you pour syrup on top of those pancakes, a lot of syrup, and let those pancakes soak in that syrup, over time, those pancakes start falling apart. At first, they look okay. Now, what's happening in your body when you have diabetes is if you don't get that excess sugar out, your blood vessels, your nerves, your organs, over time, start becoming damaged. At the point at which you feel that damage, it's too late. You cannot reverse it. So where does that leave you now in terms of taking the medicine, even though you feel okay, to prevent things from falling apart? And she said, I had no idea. And this is motivational interviewing. It's powerful.
Wow, yeah. I love that analogy of the pancake. I'm just seeing the image and how
that's right. And everybody can see, and you've had pancakes where you've soaked it in too much syrup, right?
Yeah.
And what happens to the pancake? It gets mushy and it starts falling apart. And she can then start seeing things in her body doing the same thing. And so the idea that she has that I can wait until I feel bad, now she understands why that's not a good idea.
Wow, powerful.
It's very different than looking at her and saying, you don't want to wait until you start feeling bad. It'll be too late by then. Because that's scolding. And she'll become defensive and won't listen because we cause her to lose face.
Wow.
So that's motivational interviewing.
That's great. So if we want to know more, or if pharmacists during that medication management, they have questions, where can we find you and where can we continue asking questions?
Well, I mean, what I would recommend, if you go to the APHA, American Pharmacists Association website, the second edition of my book is out, Motivational Interviewing for Healthcare Professionals. And until June 30th, it's only $20. And I think you're going to let them have my website also, right?
Yeah.
MIHCP.com. We have an 8-hour accredited e-learning program out there also, where they can learn motivational interviewing more intensively. And then on the other hand, if people want to write me an email, you have my email address, and ask a question, I'm always around and can answer questions. But the thing is, when you're an expert, it sounds easy. It makes sense.
Mm.
But you're hearing 30 years of practice when you listen to me. Now, on the other hand, I didn't have anybody teach me. I didn't have a book. I had Miller's book. And Miller, by the way, has read our book and loves it, the creator.
Mm.
Because we got rid of all the acronyms that he had and went to this sense-making approach where we teach people how to listen for how is this patient making sense? Because that informs me of what kind of targeted education needs to be done. And so we have the e-learning program. If people go to my website, there's links to the book, links to the e-learning, and lots of free videos and complimentary views, and an hour-long video of me doing motivational interviewing with a group. And it's all free. That's free. The e-learning's not free. But there are group rates also.
Mm. Wow, thank you so much, Bruce. And so our last question is, what's the advice for our aspiring pharmacists or pharmacy students?
I think the most important thing I would tell students that are coming out is don't sell out. In other words, in the United States, the average student takes almost 7 years to get through pharmacy school, including pre-pharmacy. I would imagine it's similar in Australia.
5 years. Totally.
Yeah. That's a long time of your life to invest to simply count by fives. Mm-hmm. And knowing that can be automated and knowing that information can be automated. So don't sell out to the highest bidder. In other words, here's something interesting to think about. Pharmacy is the only profession that I am aware of where our graduates take jobs rather than starting practices. Think about that. If you get out of vet school, you start a practice. Or you enter a practice, right? If you're a dentist, you enter a practice or start a practice. Pharmacy, we take jobs. And we look for who can pay us the most. And so that's what I'm saying. Don't sell out, because in the long run, you won't have a job because our profession won't exist if we don't start demonstrating our value. And our value is not by the drug we dispense. It's by caring about the patient, listening to how they're making sense, validating how they're making sense. And validating how they're making sense doesn't mean I'm agreeing with them. It means I'm letting them know I get it. I see how they're making sense of the world. The thing that will not be automated is caring. Caring is complex. Takes a human being, at least right now, to have the complexity to really understand this patient's perspective. That's the value we bring to the table. Not the drug, not the fact that we can tell somebody what moiety is on this drug, it's not on this drug. We spend 7 years here teaching students about drugs, and they don't know what to do when the patient says, I don't care, I don't want to take it. They have no idea how to respond to that.
That's exactly it, yeah.
Because drugs don't go into receptacles, they go into humans. Often make complex and sometimes erroneous decisions. Our job is to try to understand that in a way that we can present information so they can hear it. There's 3 fundamental things that affect behavior change on the part of a human being. Importance. In other words, I personally must believe that doing this is important to me. If I personally don't believe, the woman who said, I'll take my medicine once I start feeling bad, she's telling me right now it's not important to me. I have to help make it important. Second is confidence. Not only do I have to believe it's important, I have to be confident I can do it. We did a major study for Biogen, who makes the drug Avonex for MS. They had a 13% dropout rate on the drug. We found out that some of their patients were operating with the idea that this is a cure. And as soon as they had a flare up again, they stopped taking the drug because they said it wasn't working anymore. And again, instead of saying to them, no, it's still working, it's not a cure, we said, okay, so when you got that flare up again, you started losing confidence in whether the medicine's still working. And they went, right. And they had an advocate. By the way, we did a huge study for Biogen using a treatment group and a control group, and the treatment group got our motivational interviewing interventions. In 4 months, we reduced the dropout rate from 13% to 1.2%, saved Biogen $93 million.
Wow.
We published it in the Journal of the American Pharmacists Association and won their highest award for best social behavioral science publication in the year, I think it was 2009, something like that, or 13, I don't remember the year. But anyway, so this is really powerful stuff. And so, you know, we have to, okay, so I said importance, and some of the patients knew it was important to take the medicine, but they had no confidence in giving themselves an IM injection. So we had to help them with that. Okay. And the third thing, and the most important, is rapport. If the patient does not have rapport with you, they're not listening to you. And how do you build rapport? By being patient-centered, not me-centered. It's not about me, it's about them. Health care is not supposed to be an oxymoron. Those words are supposed to go together. And yet, look, how many times do we say they're a difficult patient? I've never met a difficult patient. I've met difficult situations. I've met patients who were misguided or misinformed and didn't do what we asked them to do, but that doesn't make them difficult. We call patients difficult when they don't want to do what we tell them. And the problem is, most of the time, how we're telling them.
By telling them what to do.
And scolding them and saying, no, no. I mean, how many pharmacists would you guess out of 100 when that woman said, I take my medication every day, how dare you? How many pharmacists would you guess out of 100 would probably say, well, Mrs. Jones, according to our records, you're not taking it every day?
I know I'm guilty of it. I had the exact situation. I pull out the record and said, oh, according to our computer system.
And you would be right, and you'd, you know the old expression, you'd win the battle and lose the war?
Wow.
Rather than saying, I'm really glad to hear you're doing that, and using another patient as the bad example to give her the information you want to give.
Yeah.
That requires me to give up myself.
Wow. Amazing. Well, thank you so much, Bruce.
You're welcome.
For your time
we have lots of success stories. We have a group, by the way, down in Florida, in the States, primary care physicians, several hundred in one organization. Our e-learning is their base training. Every physician, every primary care physician in their organization has to go through our training. The head of the CEO of the organization requires it. That's exciting.
It's very
Change the
important.
way they do healthcare.
Yeah. Yeah. Wow. Thank you so much, Bruce,
You're welcome.
for your time.